Let's talk about summary of acute ischemic stroke management guidelines by the American Stroke Association, which came out on 26 Jan of 2026 and is very hot right now. First point is about thrombolysis. In the old guidelines, thrombolysis was indicated in early cases who present within 4.5 hours or an extended window period of less than 6 hours with good NIHS score more than or equal to 6. Now, the latest guideline has stated that we can thrombolyze cases who present within 4.5 hours to 9 hours, regardless of NIHS score, if there is significant disability, and this 9 hours is counted from the actual onset of symptoms if the patient can recall, or if nobody can recall, it can be counted from the last non-normal point or from the midpoint of sleep if he wakes up from sleep with stroke symptoms, right? This is preferable in those cases with significant salvageable ischemic penumbra and with DWI flare mismatch cases. Second point is about thrombolytic agent tenecteplase, dose being 0.25 mg per kg body weight, which has to be given IV single bolus. 25 milligrams is the maximum dose. This is a new agent, and the old guidelines mentioned about alteplase only, dose being 0.9 milligram per kg body weight. Maximum dose is 90 milligrams. The third point is about BP. The BP should be brought down less than 185 by 110 before thrombolysis and has to be maintained between 140 to 180 after the lysis. Fourth point is about endovascular therapy, indicated also in basilar artery occlusion, who present within 24 hours with NIHS score at least 10 and aspect score at least 6. This is a class 1 indication, a very good indication, right? And EVT, or the mechanical thrombectomy, is also indicated in proximal M2 blockade of the dominant site, who present within 6 hours with NIHS score more than or equal to 6 and aspect score more than or equal to 3. And this is a class 2A indication. These two were not there in the previous guidelines. The old guidelines stated that only anterior circulation with LVO, large vessel occlusion, meaning M1 or internal carotid artery occlusions, were allowed for endovascular therapy if NIHS score is more than or equal to 6 and there is good aspect score at least 3 or more, right? Now, the sixth point is about dual antiplatelet therapy. It has to be given only in cases of high risk TIA with ABCD2 score more than or equal to 4, or in minor strokes with NIHS score less than 5, right? This has to be given for 3 weeks or 21 days according to chance 1 trial, and there is a special mention about the duration of this dual antiplatelet therapy. It has to be given up to 3 months if there is evidence of dissection in carotid or the vertebral systems. This dual antiplatelet therapy, whichever the case, should be switched to single antiplatelet therapy lifelong in these cases, right? The next point is about major strokes with NIHS score more than or equal to 6 or low risk TIAs with ABCD2 score less than 4. In these cases, dual antiplatelet therapy is not recommended and they have to be kept on single antiplatelet therapy lifelong. The next point is about ticagrelor, which is a new antiplatelet recommended now for certain cases of acute ischemic stroke. It can be given in high risk TIA cases with ABCD2 score more than or equal to 6, or in those stroke cases with clopidogrel resistance evidence. The evidence can be clinical or genetic, indicated by CYP2 19C loss of allele function. The last point is about antiplatelet therapy in post thrombolytic patients. Antiplatelet therapy is strictly prohibited within 24 hours of thrombolysis. So this is all about the latest guidelines. Hope it is clear.